Hello, my name is Caitlin Gass, and thank you for joining me today as I present a study that proposes further research on magnesium deficiency and its impact on both male and female stage 1 hypertensive patients. The specific age group of focus is individuals over the age of 65. So let's jump into first an overview of magnesium as a micronutrient. Magnesium is an important mineral found in the body with active roles in over 300 enzyme system processes. It has a role in biochemical reactions such as protein synthesis, muscle and nerve function, blood glucose control, and blood pressure regulation. Some primary sources are leafy greens, nuts, seeds, legumes, whole grains, avocados, milk, and salmon. And 10 to 30% of populations in developed countries are deficient of magnesium. Sources of magnesium can also be found in many tap and bottled water products. Deficiency can be resulted from chronic disease, medication interactions, and the overall Western diet that the U.S. as a whole has developed. It is consistent of refined foods where nutrients such as magnesium have been milled out. This deficiency can result in weakness, tremors, cardiac symptoms, depression, and agitation. Now let's take a look at magnesium's role in hypertension. Hypertension, first and foremost, has been identified as one of the most chronic diseases noted worldwide. Key factors for reduction of hypertension are management and control of blood pressure, and reducing instances of hypertension will result in a reduction of cardiovascular disease complications. Present studies focus on dietary intake, exercise, and body weight. In this current study, we'll aim to focus primarily on dietary intake. That has been promoted through the recommendation through the American Heart Association to promote the DASH diet, or dietary approaches to stop hypertension. This diet provides an increased intake of protective nutrients, including calcium, potassium, and magnesium. Magnesium is to be used as an alternative to medicine in lowering blood pressure. This could have a significant impact on public health as a whole. Certain studies have shown that daily supplementation of 240 to 960 milligrams per day has shown decreased blood pressure. In summary, further study of magnesium and its protective properties is warranted in the ongoing research to decrease hypertension. Now we'll take a look at the review of the present literature. This is just a sampling of 3 specific studies that really show a basis for dietary intervention versus supplementation and then dietary literature as a whole. Long et al. Conducted a review of the relationship between nutritional status and blood pressure. They examined a myriad of dietary intakes showing increased fruit and vegetable consumption was indicative of a decreased blood pressure reading. Zhang et al. Reviewed previously completed oral supplementation through double-blind randomized control trials with a median dose of 368 milligrams per day of magnesium. They used a median time frame of the study of 3 months, and this resulted in allowing singling out of magnesium. This showed a causal effect between magnesium supplementation and the lowering of blood pressure. And to tie these both together, Schwalfenberg and Genius designed literature to support clinical health professionals in their examination of health challenges caused by magnesium deficiency. Deficiency may cause resistance to certain antihypertensive medications, and their review showed that 500 to 1,000 milligrams per day of magnesium may also reduce blood pressure. Now for the proposed study. The disease process we aim to review is stage 1 hypertension, which can be classified by 130 to 139 systolic over 80 to 89 diastolic. The research question we aim to pose is, does consuming at least 500 milligrams per day of magnesium result in any decrease of blood pressure readings in a population of both males and females over the age of 65 with stage 1 hypertension? In correlation with this question, we also pose, is magnesium supplementation an adequate treatment used to reduce blood pressure? When we look at these questions, the overall goal for the study is to provide additional information to registered dietitians and other healthcare providers on non-traditional dietary measure to reduce stage 1 hypertension. So now we'll move into the recruitment and procedures portion of the study. The recruitment of participants will be in partnership with Northern Light Healthcare. This is a healthcare system with reach throughout much of the state of Maine. We'll be focusing on family practice and internal medicine offices, and we'll be asking these offices to offer participation in their studies to all of their newly diagnosed stage 1 hypertensive patients, and these will be through their regular scheduled visits. We'll provide a 3-month recruitment period for these offices to ask their newly diagnosed stage 1 patients, again all over the age of 65, but no difference between male or female. They'll be provided with literature to give to their patients and basically provide them with an understanding of why the study is being conducted. Participants will be provided with 2 weeks to make a decision, and then outreach will be made to them to determine if they'd like to participate. If they choose to, we'll be asked to sign a consent form. They'll have to come into the office and sign that with physician oversight, and then that consent form will be provided to the administration through the study. We'll be looking for 508 participants with 2 full groups and 2 subsets per group. Blood pressure readings will be taken and recorded prior to the start of the study. The study will be conducted through a 6-month period. All participants will be assigned a number through the study to protect their identity. This will provide that no medical information or identifying features will be provided to the administration. Again, this is why we work in partnership with a healthcare provider's system. It allows us to really safeguard these ideals through the participants' medical and identifying information. We'll have 2 main groups, again with 2 subsets in each group. We'll first focus on oral supplementation. We'll have 2 subsets of 127 individuals. This was calculated as a whole through the 508 through a G-power analysis, looking at really finding an even number to be able to divide into 4 different groups, or 2 groups and 2 subsets. It'll be conducted through a double-blind randomized control trial. The intervention will be morning supplement taken with food or meal of 500 milligrams of magnesium. The control in this subset will be no change to diet or supplementation, and these participants will be required to report and confirm their participation daily by taking the supplement and recording that online. The dietary intervention will be through DASH diet of 2 subsets of 127 individuals. In each group, the intervention will be to adhere to the DASH diet 7 out of 7 days a week for 6 months with intake of 500 milligrams per day. The control will be no change to diet or supplementation, and they will be provided with consultation through a registered dietitian. Literature and contact information will also be provided. Dietary intake will also need to be reported online, such as through the oral supplementation. This again is to safeguard that people are continuing their participation and to account for any attrition. The analysis and conclusion, we're really looking at the percentage of increase and decrease of blood pressure through calculation with subtraction from the pre-blood pressure reading. So we're going to be doing a quantitative analysis, again comparison of pre-study blood pressure readings and post-study blood pressure readings. We expect to find a decreased blood pressure reading in both intervention groups. We expect no change or slight increase in control groups. These groups, again, will be closely monitored throughout the study by the individual's physician, as they're not going to be receiving any treatment for their diagnosis of stage 1 hypertension. We'll need to make sure that they're not having any major increase or decrease in blood pressure. Again, we'll calculate the percentage of increase and decrease, as well as no change, so that we can really average and determine if there is an increase or decrease through the intervention of either oral supplementation or dietary intervention. The average results will show a mean decrease in blood pressure, and this will allow for a bigger picture to be examined of what works better, again, dietary intervention or oral supplementation. The future opportunities in this study will allow for additional evaluation of magnesium as an overall treatment for early stage hypertension, and this will provide a shift in how medical professionals aim to treat hypertension. Rather than prescribing medication, there may be an alternative through supplementation or lifestyle change. Additional skills on how to educate patients on this lifestyle change rather than a quick fix will be provided to nutrition professionals and other healthcare individuals. Further isolation of protective nutrients in similar studies, such as calcium and potassium, may be warranted. And viewing magnesium again as a conventional versus non-conventional intervention for hypertension. In summary, more concrete and consistent evidence of magnesium's role in hypertension management will be available and be provided to further education on this subject to healthcare and nutrition professionals. Here are some of my references I used. I appreciate your time and thank you for your consideration.